this is probably the single most important part of our conversation today. So Elizabeth, I want to put you on the spot and ask you to help us all understand how to manage these patients. So let me see if I can summarize. So we've decided and had a conversation elegantly around what constitutes progression. And I think that has to be made on an individual basis, patient to patient. Hard to do, in a general way. We now have FDA-approved agents that are new. We have old agents like axitinib in this space. We have new agents such as cabozantinib, nivolumab, lenvatinib, and everolimus in combination. So the practicing doctor is faced with multiple options, never having been compared with each other, axitinib compared to sorafenib, the others being compared to everolimus, all approved in the so-called second-line setting, with each of the companies knocking on their door saying, use my agent first.
Right.
How do you navigate this?
So first of all, I think we are all grateful to have so many options. I mean, 3 agents or 3 sort of treatment approaches FDA approved for renal cell in the last 6 months. So it is a very exciting time. I think even though we don't know exactly how to sequence them, we're really glad that we have them all. I think the conversation now more than ever with our patients is not which one do we use, but which one should we try next for you, right? And understanding and expecting that patients will hopefully get a chance to go through many of them. And I think at least in my practice and many of us, we are seeing patients going through multiple lines of therapy as each one emerges and is available to them. So how to select what's next for that patient, I think some of the issues that you brought up before in terms of how they did on the thing that they got before, right? If they had immunotherapy as part of a clinical trial, it probably makes sense to move to something else. If they had a VEGF TKI and did really well on that, those are the people I would think maybe we could try axitinib to extend that before we move to something else. I think, cabozantinib has come along, and in that study, they were allowed to have prior PD-1, they were allowed to have more than one prior therapy, so we have a little bit of evidence in that setting for cabozantinib. I think the one that's most challenging, at least for me, is figuring out how to place lenvatinib with everolimus. It's different in a lot of ways. It was a smaller study. It's a combination therapy. It's the first time we've really had FDA-approved combination therapy in renal cell. And I think in my mind, the bar is a little bit higher for that combination. It's more expensive in terms of toxicity to the patient, in terms of societal costs. And again, figuring out where that goes, I'm not sure. But I can say I think everolimus probably won't be given without lenvatinib so much in the future, given that we do have comparative data in that setting. So no clear answers, but I think lots of room.
Let's just clarify one area, and I want to get some opinions of other panel members. Elizabeth, you made the comment that response to prior therapy may dictate how someone will do in the next line.
Maybe.
Tom, your thoughts about that?
That has been the MO that all of us have used in practice without data to support it. In fact, the data is actually opposite, and the data is really retrospective. We have European data from the Italian groups, been prolific in some publications, and then the largest data I'm aware of is our international consortium with the KCA-sponsored data set from Danny Hang and Tony Choueiri, and in that data it's clear that response and even toxicity to frontline therapy doesn't predict response and toxicity to second line. But I hear what you say, Elizabeth.
No,
a lot of us all apply that as how we choose, but it's very difficult.
Nizar?
So I think just to go back, I think it's important to mention about the pseudoprogression. I think this is really important. In my opinion, the percentage of patients who really have pseudoprogression is in the single digit. It's 5%, and this is true for melanoma as well as renal cell. So I think what the take-home message that we have to give to community oncologists is, if a patient, and David, you mentioned that, if a patient is having symptoms on therapy with a PD-1 or a PD-L1, and they continue to have these symptoms, and they develop, say, not a small lung nodule if they have already lung mets, but now they have bone mets that's symptomatic, those patients should not continue with their therapy because they are real progressives. And if a patient, let's remember that only 25% of the patients on the CheckMate 025 study had a major response. So most patients are not going to respond. And I think if a patient is already, I'm going to use the term on fire, time is of the essence. We cannot continue with therapy. saying that this is pseudoprogression because time is of the essence. You really need to switch therapy before they end up with hospice. So I think this is an important point. Now the question that you posed to us about how do we now sequence these 3 therapies? I mean, I will say there are 5 therapies. You have nivolumab, you have cabozantinib, you have the everolimus combination, axitinib is there, and then of course everolimus was there up to just a year ago or less. So I think in my opinion, the ranking has to be IO, Cabo, or Cabo IO, and then the rest are dropped. I think axitinib, in my opinion, everolimus single agent, I mean, 2 phase 3 trials showed survival advantage with nivo over everolimus, with Cabo over everolimus. So to use everolimus alone, except for that patient whose tumor harbors, we talked about this already, the TSC1, TSC2, the mTOR gene pathways mutations where they may have a response. Now, I have to say I cannot embrace lenvatinib plus everolimus right now based on a 153 patient randomized phase 2 trial. That's not powered to, and so 2 patients, if you took 2 patients from one arm to the other, they'll change the whole statistic. It is toxic, so 75% of the patients who received lenvatinib everolimus had dose reduction. And you had 25% who discontinued therapy because of toxicity, compared to 8% with nivo alone, compared to 10% with Cabo alone in the phase 3 trial. So I can't put this in the same par with nivo and Cabo. So I think an important consideration when we talk other than toxicity and cost is the patient. So there are patients who like to take an oral agent, even if you convince them, look, you need, immune checkpoint inhibitors is going to provide you with a better quality of remission. The other issue is the toxicity. So if a patient has history of Guillain-Barré post-viral, and I had that patient who had post-viral Guillain-Barré, orthopedic surgeon who had 2 prior TKIs, I wanted to give him nivo, but then I couldn't when he had the Guillain-Barré. And the patient who has nephrotic range proteinuria from prior TKI, you're not going to go to cabozantinib in that patient. You prefer, once their proteinuria resolves, to treat them with nivo. I think the important thing to mention about the IOs here is that, in my opinion, toxicity is less when you use just PD-1, PD-L1. But what you look at that's important here that may not be provided by any target agent is that tail at the end of the curve, that quality of response. And I think, David has published on this from the phase 1 trials and the phase 2 trials. You may have a 10-15% of the patients who are going to be in remission 3, 4, 5 years and beyond. And I think, this we're all waiting on these long-term survivors in remission, similar to the story with IL-2. If that holds up for, 5 years and longer, then I think, you have to give the nod to IOs as the first one of the sequence.